Hey, this is Brad Block, host of The Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle. Welcome back to the podcast. We have an amazing guest today, and we're going to be talking about improving our communication in healthcare. And as you all know, that's something we talk a lot about on the show, and I cannot believe it's taken me 6.5 years, and now I finally have the president of the Academy of Communication in Healthcare on the show. So on today's episode, we have Dr. Timothy Gilligan. He's an associate professor of medicine and a medical oncologist specializing in urological malignancies at the Cleveland Clinic, where he is the associate director of communication skills course in the medical school. He served on the leadership team that developed and launched the Cleveland Clinic Center for Excellence in Healthcare Communication. He co-edited the book Communication, the Cleveland Clinic Way. So you guys, you're getting the theme here, and it's something he's passionate about. And as I said, he's currently the president of the Academy of Communication in Healthcare. He's also the DEI officer for GME at the Cleveland Clinic, and he's now focused on developing educational interventions related to allyship and microaggressions and developing an anti-racist culture. Dr. Gilligan, thank you so much for being on the podcast.
Thank you for having me. It's a pleasure to be here.
So before we get started, just a quick word from our sponsors. And we're back. Dr. Gilligan, tell us a story of a patient who refused treatment where you used your communication skills to get them to come around. And so for the listeners, he had written an article about it where the term, it's something actually I call my kids. The patients who refused treatment were referred to as knuckleheads, right? Because we're like, why would you possibly do that? But we're going to get to the heart of the matter, which is understanding that in your communication. Dr. Gilligan, if you could give us a story that illustrates how you broke through in a situation like that.
Yeah, so I won't tell the knucklehead story again because that was just recently published. But interestingly enough, I have a very similar story that happened at the beginning of my work in this field. The timing of it seemed like a bizarre coincidence at the time. I just started formal training in how to teach communication skills. And one of my mentors had said to me that when you talk to someone who has a serious illness, it was really important to find out who they were before they got sick. And the serious illness strips away important elements of people's identities, that when you suddenly have advanced cancer, you may not be able to work, you may not be able to play with your kids, you may not be able to have sex, you may not be able to play your sport, you may not be able to concentrate. All sorts of things that used to make you who you are can be taken away from you, and your self-image can change. And he said it's really important to find out who that person was before they got sick and to allow them to make sure that they know that you see that identity. And so I literally got off the plane from that course and went back, and I was on call in the hospital, and one of the fellows came up to me and said, Dr. Gilligan, we have a patient with testicular cancer, and that's my specialty. They said he has advanced cancer, he needs chemo, and he won't let us treat him. And I said, what do you know about him? And they said, he has seminoma. I said, what else do you know? It's a seminoma of the left testicle. I said, what else do you know? It's spread to the back of his abdomen. What else do you know about him? He's saying he doesn't want chemotherapy. And I'm thinking, all I know about is the cancer. I have no idea who this guy is. So I went in and I talked to him, and my mentor's words were ringing in my ears. Find out who he is before you talk about treatment. And he had the craziest story. He had recently been thrown out of the apartment he shared with his girlfriend. And his girlfriend had told him she was running off with another man. And she was pregnant, and she wasn't sure if the baby was his or the other guy's. And when he had found out he had a lump in his testicle and had scheduled surgery to have the testicle removed, his mother had tried to cancel the surgery and said, Jesus is going to save my son. And his father had lung cancer and had recently relapsed and was now terminally ill. And he said he was really wondering who was going to come visit him in the hospital. He had a new girlfriend, and he was wondering, would the new girlfriend come to the hospital, or would the girlfriend who was pregnant and had thrown him out, was she going to come to the hospital and maybe want to be with him? And the logic, you might think, isn't the soundest logic, but his logic was that if the pregnant girlfriend came in, then he was already a father and he didn't need to preserve his fertility. But if the new girlfriend came in, he might want to have a baby with her, so he better preserve his fertility. Again, not necessarily the clearest thinking, but logical nonetheless. And what seemed to me was that this is someone who had been abandoned by everybody. Like his girlfriend had abandoned him, his mother had abandoned him, his father was about to abandon him. And what he was worried about was, who's still there for me? Who's going to come into the hospital? And starting treatment for his cancer was not at the top of his list. So we talked about all of this, and I didn't even talk about treatment with him. I think I asked him, what if people told you about what's going on? And he said, They said I need chemotherapy. And I didn't even say anything about it. I came back the next day and we talked, and 2 days later he started chemotherapy and he was cured. I followed him for about 7 or 8 years and he never relapsed. And what was striking to me about it was that...
Dr. Gilligan, who ended up visiting him? Who was it on the edge of my seat? I want to know the end of the story. Who visited him?
It's interesting. I actually never saw anyone visiting him in the hospital. Now, that doesn't mean that they didn't.
We make rounds at 6 a.m. and
we make rounds early in the morning. And that's, in some ways, that's a failure on my part. I should have made contact with them. I made a very strong connection with him. I didn't meet the other people in his life. And whenever he came in to see me, because I followed him for many years, and I told him I was going to write about it, and he said it was okay with him. I followed him for many years, and he never came in with anyone else. He always came in alone. I always heard his stories, what he did for work and what's going on in his business and all that kind of stuff, but I never met any of the people in the world.
That's interesting. I had someone on the show a while ago, and one of the things that we talked about, and this is someone who ended up actually giving a TED Talk on this subject, which is something that we hear a lot in medicine, which is it's all in the history. The reason to talk to the patient and to get a good history is because then you can make the right diagnosis. And I had one of my listeners who's actually been a host on this show as well. His name is Scott Abramson. He's a retired neurologist from out in California. He's been doing communication with Kaiser for 40 years. And he wrote me an email. He said, listen, Brad, a lot of communication in healthcare is not that. It's trust building. It's not just to come up with the diagnosis. It's to build trust, because you can walk in that room and come up with the diagnosis, or they come in with a diagnosis in their hand already. You don't need to get a history. You can just tell them what's going on. But a lot of communication in healthcare is trust building. What are your thoughts on that?
No, I think it's really important. I think one of the main things, I ran our fellowship program for 10 years, and when I would sit in and listen on fellows interviewing, I realized that a lot of our trainees were being trained to carefully review the chart, which is really important. You can't go into the room and not know what's going on. But they would go into the room and they would tell the patient their history. And there's a certain power in speaking. And if we relegate the patient to only listening, we're stripping them of power. We're telling them their story. Is their story. They should get to tell it. So I actually try to be very disciplined. I think one of the ways I build trust is I listen and I show sincere interest. And I want to hear from their perspective. And so I might say, look, I've read your chart. I think I know the story. I really want to hear it from you, because I don't want them to think I don't know what's going on. But I want them to talk. I want them to tell me they have cancer. Because they, as you said, they usually know before they come in. They don't get sent to the oncologist so someone else figures they have cancer. They know. So I'll ask them, what have the other doctors been telling you about what's going on? And what questions do you have about it? And how can I help you? And I really believe that listening in the beginning of the interview is really important to build trust, because it shows that you care what they have to say and you're curious about them and you're interested in learning and you value the fact that they have a really important perspective. I know about cancer, but they know about their body and they know about their life and they know about their priorities. And if I show that's important to me, I give them more of a reason to trust me, because I think you're exactly right. I have to earn their trust. I worry that people feel like, oh, I have a white coat on. It says MD after my name. I'm entitled to their trust. I don't feel like I'm entitled to anyone's trust. I feel like I have to earn it. And if you go in and I think with that attitude, listen, show curiosity, show respect, show sincere interest, those are helpful skills for developing a trusting relationship.
But you're Dr. Gilligan, the associate professor of medicine at the Cleveland Clinic, right? They've traveled, some of them hundreds of miles or more, to see you. That doesn't earn you the trust by itself?
Yeah, no, I don't think so. I don't think so, especially not in this day and age. Maybe 20 years ago. I actually think that they come in with less trust than I would expect them to. That is, I feel like they don't come in with distrust. I don't necessarily feel like I've earned trust. I also don't think I've earned distrust. I'd like to start out somewhere neutral. But I don't know. I think it's more fun to practice with less hierarchy. My mentor in medical school was a guy named Tom Raffin. He was the head of pulmonary and critical medicine at Stanford. He's also the head of bioethics. And he didn't like to wear a white coat. And I asked him why not. He said, because it interferes with my relationship with my patients, that he wanted to go in and talk to them as a human being. And he didn't want to be lording this authority of his knowledge over them. It's very easy for us to overpower patients with our medical knowledge. We obviously know more medicine than they did. We went to medical school. And even if they're also a doctor, we're a specialist in what they have. And I'm very wary of doing that. And I think if we can flatten the hierarchy, that I have my sphere of expertise, they have their sphere of expertise. We work together to find the right answer for them. And I really try to stay away from telling them what to do. I don't think adults like to be told what to do. I think they like to make their own decisions.
Oh, yeah. Psychological reactance. Happens in kids and adults. You tell someone what to do, and it makes them less likely to want to do it.
Right. It's like, you're not the boss of me.
Exactly. They'll do stuff despite themselves just to gain some autonomy back. And to your point about the white coat, they also get very disgusting very fast. So it's like white with yellow spots after a little while.
And I'm not saying no one should wear a white coat. I just found that story from Tom really interesting and it had an impact on me.
Right. But leveling. And then also when you're communicating with them, leveling yourself physically. So you're not lording over them physically. So finding any way that we can flatten out the hierarchy in that situation is going to help towards trust building and communication. That's what you're saying.
Yeah, and you're right. Being at their eye level is really important. I learned that as a parent. When I had a young kid, my first child, when she was 2 years old, if I stood up and looked down at her and she was looking up at me, it was a very different conversation than if I got down on my knees and we were at eye level. Suddenly we're equals and we can relate in a very different way.
Yeah, absolutely. Staying on eye level, trust building, asking the patient things about themselves. It seems like there's like a checklist developing of things that need to happen during these visits. And ever since the checklist manifesto, doctors are either love checklists or hate them, but checklists are definitely here to stay. So do you have a mental checklist of things that have to happen during a patient interaction, like communication must-haves?
I do, yes. I think part of it has to do with mindset. One piece of advice I got early on, which has been very helpful to me, is to do a reset before I go into each room. Like I'm leaving a room and maybe I had a really difficult conversation. Maybe I had to give bad news. Maybe someone was really upset. Maybe someone was really disappointed, or maybe it was really happy. But whatever emotion was really present there, when I go into the next room, it doesn't help to carry that in. This is a different patient, different story, different situation. And one trick for doing that is just to take 5 or 10 seconds and just feel your feet on the floor and take a couple of deep breaths and just get yourself back into the moment before you go in. So when you go in, you really can be present. I think if you go in with a sort of harried, distracted, like you're carrying all this baggage from your last, whatever you did, maybe a lunchtime meeting with your boss or something, whatever, you don't want to bring that into the room with the patient. So you can really come in fresh. Because I think first impressions make a big difference. I think how you come into the room makes a big difference. One of the metaphors we use when we're teaching communication skills at the Cleveland Clinic was, these are guests in our home. I go to the clinic every day. That's where I live during work hours. It's not where they live. It's foreign territory. They may be scared. They may be worried. What am I going to tell them? What are they going to have to do? What is their prognosis? And I think of it like if I have someone over to my house, there are things I know to do to make someone feel welcome. What can I do to make my patient feel welcome? Dan George, who does geo-oncology at Duke, was one of my important clinical mentors early in my career. And he would have a big smile on his face. He'd shake the patient's hand. He'd say, welcome to the clinic that we're working in. And I paid attention to that. It was just a very warm greeting. And that may not be my style. I wouldn't do it exactly like he does. He did it in a way that's authentic to him. But the point is, he made the patient feel welcome. He made them feel like, I'm really glad you're here. And I think like thinking about how we start off that way is important. And then early on, I really try to keep my mouth shut.
I couldn't even do it right now.
It is hard. And yet, I think it was Walter Bale, one of my mentors in communication skills. He's a psychiatrist at MD Anderson who taught communication skills. He or one of my other mentors used to say, every time I open my mouth, I risk making things worse. And I feel that's very true at the beginning of an encounter. I'm much better off just listening than making the wrong impression by saying the wrong thing. And if I don't know who they are, and I don't know what they're expecting, and I don't know what they already know, if I say too much too early, I might say the wrong thing in the wrong way and alienate them. If I listen and if I watch them carefully, look at their body language, does it look like they're having a good day, a bad day, nervous, or like confident? What can I pick up by watching and listening so that when I start to talk, it's from an informed perspective? It's why it's so important to me to ask patients, what have other doctors told you about what's going on? Because they may have a lot of knowledge. They may have a lot of incorrect information. I don't know where to start the conversation until I know where they're at. And so that, for me, I feel like if I started off right, it's much more likely than to go more easily. And with a couple other things, we tend to be very cognitive in healthcare and really think about what's the information the patient needs. And if the patient's having strong emotion, they don't really need information. What they need is empathy from us.
They're not going to understand complex health information. They're not going to retain the information. Oh, it sounds like you've got to build them up first to be able to put them in a place where they can understand and retain.
And sometimes we respond to strong emotion as if it's a problem, and our job is to make the strong emotion go away. And for me, there's a certain absurdity to it, because when a doctor gives you really important news, it's normal to have a strong emotional reaction. If it's bad news, it's normal to be sad. If it's happy news, it's normal to be happy. And yet, if you tell someone bad news and they start to cry, we often try to figure out how to get them to stop crying, when in fact crying is the appropriate reaction. It just means they understood what we said.
So this is like one of my earlier episodes where I had a disagreement with one of my guests about crying, because what I was taught in medical school was if the patient's crying, get them a tissue. And what they were taught in medical school is if you get them a tissue, that message is that they should stop crying. And so what do you do if someone's hand them a tissue? Or, I know it seems trivial, but like, I want to say,
yeah, no, I don't think it's a signal to stop crying.
Okay.
I think it's an acknowledgement that you see that they're crying. If someone is sitting there crying, they have tears running down their face, they're trying to figure out what to do with the tears, they're wiping with their hands are getting messy. I can't think of a time ever that I've handed someone a tissue and they haven't said thank you. Because you're helping them. Their face is all wet. They want to dry their face. To me, it's not at all telling them to stop crying.
Okay, good.
No, it's okay. We're going to pause now and acknowledge that you're really upset instead of charging ahead with our business at hand.
Okay. Anything else on the checklist? Anything else on the must-haves during each encounter?
So I think there are a couple of traps we fall into. We respond to emotion with empathy. I think when we are asked a challenging question, we often feel like we have to answer it. I think it's really important to remember that we don't have to answer questions right away. I'm not saying refuse to answer questions. What I'm saying is figure out what the patient really wants to know first. So it's often helpful when a patient asks a challenging question to ask them what they really want to know. So if a patient says, how much time have I got? It sounds straightforward. It sounds like what they want to know is 2 months. But that's often actually not what they're asking. They're upset, they're scared. If you imagine being in a situation where you're having to ask a doctor how much time you have left, that's a terrible place to be. There's going to be a lot of emotion around that. And it could mean a lot of things. It could mean my daughter's getting married in 3 months. Am I going to live to see it? It could mean, oh my God, I just realized I'm going to die. I wonder how long I have. But they're not really wondering, because oftentimes if you say to them, I'm happy to answer that question, that's a really important thing to discuss, I'm wondering what you really want to know, my patient will often pause and think and then ask a very different question. Or I'll say, do you want to know the answer to that? And they'll think about it and they'll say, well, you know what, actually I don't. I almost feel like they're supposed to ask that question, but it's often not very useful information. Sometimes it is. There are times you really need to know. I'm all for telling patients the prognosis, but we get these challenging questions, and if you get asked that question 5 different times, it can mean 5 different things. And if you take the time to figure out, what is this individual patient really asking me? What do they really want to know? I think we can serve them better. And we can take some of the work off of our shoulders. That sometimes it feels like it's our job to make everything okay. The fact is we can't make everything okay. And I think if we realize that and accept it, we can be much more effective. Actually, I have a short story about that really impacted me in a big way, if you don't mind me telling it. Please. I had a patient that had a cancer that I hoped might be a testicular germ cell tumor and therefore might be cured with high-dose chemotherapy, but I wasn't persuaded that's what it was. I thought it was not a germ cell tumor. It was just a poorly differentiated cancer. And I said, why don't you go see Larry Einhorn in Indiana, just to make sure that he knows more about this than anyone. I'd like to get his opinion about whether or not you should have a transplant. So they go and they see him and he says, no, this isn't a germ cell tumor. You shouldn't have a transplant. There's really nothing more we can do to treat the cancer. And his parents come back with him. He's a guy like 22 years old. The mom and dad are there. And his mom says, thank you so much for sending us to see Dr. Einhorn. And I said, tell me, what was so helpful? And she said, we asked him, should he have a bone marrow transplant? And Dr. Einhorn said, no, this is not a testicular germ cell tumor. It's not going to respond to high-dose chemotherapy. He'll just suffer from side effects. There really isn't more treatment for this that's going to help him. And she said, Dr. Einhorn, my husband's a minister and we're very religious people, and I'm just really trying to accept this. And Dr. Einhorn said to me, you can't accept this. This is unacceptable. And the message I got from the mom was, those words made the 5-hour drive to Indiana worth it to her, that this famous doctor acknowledged this is completely unacceptable. It's going to happen. We can't stop it. But it's completely unacceptable that we can't save this boy's life. And I thought it was a brave thing to say in a way, because I feel like people tend to say nonsense stuff. God doesn't give you more than you can handle. And that's a really arrogant thing to say to someone who's suffering, I think. And I thought what Dr. Einhorn was doing was the opposite of that. It was so compassionate. Yeah. And it was very simple language. It wasn't like he said something fancy. He just made the mom feel like, I see what you're going through and it's awful.
That's an amazing phrase, I think, for some of us to be able to keep in our pockets to take out in those types of circumstances, because that sounds like a really powerful thing to say. Acknowledge how awful that is. Speaking not to the practicality of what we're going to treat and how we're going to treat it and what workup of next, but just acknowledging the awfulness of what they're going through. Be there with them for it. We're talking about bad news right now, and we're talking about checklists. So I was wondering if you could weave those two things together. Do you have, because as an oncologist, you're delivering that news.
For bad news, I actually like the spikes protocol. Walter Bale was one of the people who developed that, who I mentioned earlier. And so basically the checklist there is the setting. Are you in the right environment? You don't want to have a bad news conversation in the hallway. You don't want to have the bad news conversation if the right people aren't there. I've had residents give a patient of mine really bad news at 1 o'clock in the morning when his parents weren't around, and it could have waited till the morning when mom and dad were there and could support him. You don't have to do it right away. You can do it when the right people are there at the right time. You want to make sure that they're open to it. Is this a good time? I have some important news to talk about. I'd like to try to give the patients control over things. They might say, no, could you do it later when my partner's here, my parents are here, I'm too tired right now. So making sure it's okay with them. So I have the setting, I have information. I want to know what their perception is of what's going on. What do you know about the situation? I want to talk about your CT scan results. Do you remember why we were getting the CT scan? Or if I'm not the first person to talk to them, what have other people told you? I want to know where I'm starting from. So those are key steps on my checklist. If I want to make sure I have the right setting, I want to get permission from them to share the information. I want to find out what they already know. The K in spikes is knowledge. Then I give them the information. I give the information after I have made sure I have the right setting, gotten permission from them to share it, and then found out what they know already. So I give them knowledge. Then E is really for emotions and empathy. If you give someone bad news, they're going to respond with emotion. I need to acknowledge their emotion. I can see you're upset. I know this is really hard to hear. Whatever, just acknowledgement of what they're going through. We can talk about empathy separately. There are a number of different sort of practices for that. And then finally, summarizing next steps. After we give them the information, empathize with them, and then they really need to know what comes next. It's really a shame if we do a great conversation and then we walk out and the patient's, I don't know, what's the next step? When do I see you again? What do I do for tests and stuff? So that's, for me, is the checklist in my head. And the other piece I would add is that when giving bad news, it's very important to be short and sweet about it. And what I often see happen is that the doctor keeps talking, hoping that, it sounds like the doctor thinks if they talk long enough, the bad news will magically change into good news. Like my sarcastic version of this is, your lung cancer has spread to your brain and your liver and your bones, but the good news is we have a really exciting clinical trial for you. And it's just trying to change the subject, trying to reassure them, trying to distract them from the fact that,
trying to move on to then talk long enough and we'll be moving on to the next subject so we won't have to dwell in that discomfort.
So the alternative is just to say your cancer has spread to your brain and your liver and your bones. And then stop talking and see what happens. And it's the patient's turn to talk next. I think of it as like dropping a pebble into a pond and you want to wait till all the ripples have stopped before you speak again. And if the patient doesn't say anything, I'll say, what's going through your mind? I know that wasn't easy to hear. What are you thinking? What are you worried about? Or if they start to cry, then I'll acknowledge that. But I think we get uncomfortable. We've given bad news, we get uncomfortable, and then we fill the room with words. And it's much more effective to allow silence. I think it's very empathic. It says to the patient, I'm going to wait for you. I'm going to wait till you're ready to talk.
You know what that reminds me of? That reminds me of when my kids are having a meltdown. My kids are having a meltdown, and the best thing I can do is just be their rock. So just be unflinching, unmoving, empathetic, but not like going with them. And so just being still, which it's hard and uncomfortable because it's easier to be like, calm down, stop crying, try to make their discomfort go away, rather than letting them find their way back from discomfort to comfort, because it's easier to try to facilitate it than to just sit with it. And so by sitting with it, it's uncomfortable for us, but we have to live with that discomfort. We have to be skilled in handling that discomfort and experienced in it because they're not, and we need to be there for them.
That's right. Actually, I think that's really important. And it's a great analogy, right? Like you're a parent with your child, they get really upset. You can handle whatever upsetness they have. Now, with the patient, I don't think of it as a parent and child. I really try to flatten the hierarchy there. But I'm used to being in that room, and I'm used to this level of bad news, and I'm used to being with this sadness. And I honestly think it helps my patients if I can just be okay with them getting really upset.
Yeah.
And not need to stifle their upsetness, but just let it happen and support them.
Acknowledges that this situation is not okay. As your colleague put it earlier, you're sitting with that discomfort. Okay. I want to move on to how you teach, because you're not only do you teach medical students and residents, your role is in communication at the Cleveland Clinic is you're teaching attendings too. And so there's a different, we're talking about dynamic between the doctor and patient. Now you're talking about the attending to attending dynamic. How do you communicate, or how do you teach communication skills to an established attending? We have our ways of doing things. So how do you divert that train?
Yeah, no, that's a really good point. Adrienne Boise was the leader of our team when we started our thing. And I think she was really helpful in recognizing that problem very early on. And we thought about it a lot. From day one, our attitude was it would be arrogant, seriously arrogant for us to go into the room and talk to a doctor who's been practicing for 10 years and tell him or her, I know how to communicate with your patients better than you do. That would be really arrogant. And so we really didn't want to be coming across as doing that. And so we really, when we were working with attending physicians, we really took the attitude of, we're at the same level as you. We know how to have a conversation about this and we know how to teach this, but that doesn't mean that we're better at it than you are. And that everyone in the room, we used to teach groups of 8 to 12 people. We'd say everyone in the room has expertise in this. We all have experience and we can learn the most if we learn from everyone in the room. And our job as teachers is to facilitate a learning experience. It's not to tell you that we're the experts and we'll tell you what to do. But we think there's a lot of expertise in the room, and if we can all put our heads together, we'll come up with the best answers. And we actually saw some of the most effective teaching was peer-to-peer. And if we could just set up an environment in which they could talk to each other, like different members of the class, they all came to learn communication skills. Them teaching each other was often more effective than us trying to teach them. And I think that one thing we really tried to emphasize was this is hard work. All right. You imagine you're an emergency room physician and some young mother is killed in a car crash and the husband comes in or the wife comes in, if she's married to a woman, or the partner or whatever, or the parents or the kids, and you have to tell them this person died in a car crash. What a horrible thing happened, but also what a horribly difficult task you have. And so when people say doctors don't communicate well, yes, we could communicate better, and we're doing really hard communication. So it's not surprising that we don't always get it right. We're doing 10 out of 10 difficulty conversations a lot of the time, and they're hard. And
with strangers where you're not coming in. It's not like you're getting this news from your trusted primary care provider that you've been seeing for 12 years. You're getting this news from someone you've never met that doesn't know you from Adam.
Exactly. So I think we entered it with humility. And I think we'd also often use sports analogies. I have a bad habit of using tennis as an analogy for everything. But I used to have this slide of Serena Williams working with her coach. And I'm like, if Serena Williams thinks she's not good enough yet at tennis, it's really hard for me to say I'm good enough at communicating. Roger Federer was going out and practicing hours every day. He didn't say, I'm number one in the world, I can stop practicing now, I don't have to get better. And so we tried to be aspirational. We're professionals. We always want to get better. Like the famous Steve Jobs quote that good enough isn't, which I think is a great line, but we always want to be better. So however good we are, we're not saying you're a bad communicator, we're saying you're a professional who always wants to get better. So let's get better at communicating, because communicating is a really important part of what we do and we don't get to practice it. And I think the thing that's great about the classes is that when I go into a room with a patient and I have a visit, I don't have any reliable data about whether I did a good job. If I go back to my boring tennis analogy, every time I hit the ball, I get feedback. The ball goes in or it goes out. If I'm trying to hit it down the line and it goes cross court, I did something wrong. I don't get that feedback with the patient. Maybe they look like they're happy with me, but I can't really tell. Whereas if I'm in a classroom situation, I'm getting observation and I'm getting feedback. I'm finally getting some information of here are some things I'm doing that work and here are some things I'm doing that could be done more effectively if I did them differently. And it gives me a growth opportunity. So I think working with attendings, we were very careful to be humble and to create a learning environment and to invite them to practice their skills and to learn. And we had a very positive experience because people came in very skeptical. And by the end of the day, they usually were really happy they were there, because what they felt like was they realized they weren't alone. They weren't the only one who was struggling, that all their peers were struggling with the pace at which they had to work and all the paperwork and the difficulty of some of the conversations they had to have. And I think that feeling of camaraderie was really helpful. And we had data that not only did patient experience scores improve, but some measures of burnout improved and empathy improved.
Satisfaction. Yeah. Provider satisfaction.
I have nothing wrong with provider. I'm all for flattening hierarchy. Some of the best clinicians I've worked with are not physicians. I think doctors get hung up on that.
I agree. I totally agree. I was half joking. I think it's an umbrella term, and there are a lot of different people under the umbrella of provider. Stop getting upset about it. And the fact that it's from Nazi Germany is totally untrue. That's been debunked. That's just more inflammatory speech. I was hoping, because I have so much more I want to ask you, that you could spare a little more time. Is that okay?
Yeah, I'm in no rush.
Thanks for listening. So please share it, or like it, or comment on a social media post, or write us a 5-star review. Thank us again for listening to The Physician's Guide to Doctoring.